Hi, welcome to Civics Change Agent Chat Episode 21. During these chats, we speak with change agents who are working to create a better healthcare system for us all. I'm Stephanie Spriggs with the Center for Improving Value in Healthcare, or as we like to call it, CIVIC. Today's chat is a bit of a departure from our usual format. Change agent Tessa Crume, Associate Professor of Epidemiology at the Colorado School of Public Health, presents preliminary findings from her team study, Population Surveillance of Adolescents and Adults with Congenital Heart Disease. The Colorado School of Public Health assembled a team of epidemiologists, health informatics, adolescent and adult congenital heart disease cardiologists to develop a statewide, population-based surveillance system of individuals living with congenital heart defects in Colorado. The team used CO APCD data to estimate the burden of congenital heart disease among adolescents and adults in Colorado, identify factors associated with long-term outcomes, and assess issues that impede the transition from pediatric to adult-centered cardiac care. We recorded this chat in May 2019. Thanks for listening and enjoy the chat.
Okay, I'm Tessa Crume. I'm an associate professor of epidemiology at the Colorado School of Public Health, and I also have an appointment in obstetrics and gynecology at the School of Medicine at the CU Anschutz Medical Center. And I'm going to talk to you today about a project that we've been working on over the past 4 years called Surveillance of Congenital Heart Defects Across the Lifespan. And I'm going to talk to you about how we've developed a population-based surveillance system in Colorado, which we call the Colorado Congenital Heart Defect Surveillance System. So today I'm going to talk about the background of congenital heart defects, why surveillance is a public health priority, how the Colorado CHD surveillance system was developed. I'm going to talk about some of the strengths and limitations of integrated surveillance that we have discovered in embarking upon this project. And then I'm going to present some of our results, which will describe the epidemiology of congenital heart defects in Colorado in terms of prevalence, healthcare utilization, and comorbidities among individuals with CHD. And I'll also talk about some of our other research findings that relate to the prevalence of mental health diagnoses among individuals with congenital heart defects, and our findings on the transition from pediatric to adult-centered cardiology care for individuals that are in their late teen or early 20s. And finally, I'll talk about the public health implications of our findings. Congenital heart defects encompass any structural abnormality of the heart or intrathoracic great vessels that is present at birth. CHDs are the most common type of birth defect and are estimated to affect nearly 1% of all births, or about 40,000 births annually in the U.S. The ability to perform open heart surgery with the introduction of infant cardiopulmonary bypass in the 1960s transformed what was previously a fatal defect into a complex chronic disease. A little bit about the etiology of congenital lesions. It's estimated that at least 15% of CHDs are associated with genetic origins. About 20 to 30% of individuals with CHDs have other physical problems, developmental or cognitive disorders. Children with CHD are about 50% more likely to receive special education services compared to children without birth defects. And the occurrence and severity of a developmental disability or delay increases with the complexity of the heart defect. For example, more than 80% of individuals with a mild heart defect have no developmental disabilities. However, more than half of those with a critical type of CHD have some form of disability or impairment. Survival for individuals with CHD has changed dramatically over the past few decades. In 1987 and 1988, the majority of mortality for individuals with CHD occurred within the first few years of life. Contrasting that to 2004-2005, the lifespan of an individual with CHD is quite similar to an unaffected individual. So why is CHD a public health surveillance priority? It is unknown what the prevalence of CHD is in the United States. Our best estimates come from surveillance data in Canada that's been extrapolated to the US population and adjusted for our demographic composition that differs between the US and Canada. So based on those estimates, it's thought that approximately 2.4 million people are living with CHDs in the US. Even after an individual has a successful reparative surgery, they are not free of a defect for the rest of their life. Individuals with CHD have complex conditions that require lifelong disease management, and most have to have several repairs of their original repair over the life course. There's a high degree of comorbidities in individuals with CHD that are due to the complex nature of their physiology, which is both a nature of the individual defect and the surgery to repair that original defect. And aging for individuals with CHD brings unique challenges for lifelong cardiac care. Research in the adult population with CHD in the US is scarce, due in part to our disjointed healthcare system that precludes estimates that are available in Canada or Europe, where they have single-payer healthcare systems. So most of what we know about CHD incidence in the US is based on state-level birth defects registries. However, each registry conducts surveillance with different methodologies, so you can't pool the estimates across the different registries to get a national estimate. And most use a combination of active and passive surveillance. So higher levels of ascertainment in one state don't necessarily mean they have a higher level of that birth defect. They may just have a more aggressive surveillance system. And extrapolating the prevalent population from incidence at birth is inaccurate because many individuals with a CHD are not diagnosed in the first 3 years of life. And there are, of course, mortality experiences, which would make extrapolations from birth incidence to adult prevalence or adolescent prevalence misleading. So in Colorado, we were one of 5 sites to get funding from the Centers of Disease Control to develop a population-based surveillance system of adolescents and adults with congenital heart defects from existing medical records and insurance claims. The goal of our project was to describe the epidemiology and prevalence of congenital heart defects at the state level in Colorado, and to understand healthcare utilization patterns and health outcomes. And finally, since this is a novel effort to develop a surveillance system based solely on administrative data, we want to evaluate the strengths and weaknesses of our surveillance system for a rare chronic disease. The steps that we have conducted to develop our surveillance system include engaging healthcare organizations and public health agencies across the state as partners in surveillance, and Civic was one of our key partners. We also partner with the State Health Department, our other primary data sources, which I'll describe, and we have a patient advisory group. Our next step was to develop a comprehensive cohort of CHD cases utilizing various Colorado data sets. So we used a structured case definition based on diagnostic coding and geographical residence, and then an age range. And we performed record linkage and deduplication of our cases across those data sets. We performed a case validation on a subset of cases to determine how well our ICD diagnostic case definition actually captured true congenital heart defect cases. And then we explored the extent to which bias was introduced by incomplete case ascertainment, because we did not get full participation of all healthcare providers in Colorado. We engaged a patient advisory group, which meets quarterly to help us to understand our results, identify priorities for research, and they are key partners in our advisory group. And now we are in the process of disseminating our findings on CHD health and non-health outcomes to further quantify and assess the burden of congenital heart defect in our state. So this figure shows the case ascertainment flow from our primary case finding data sources. Our primary sources were Denver Health and Hospitals Association, Kaiser Permanente of Colorado, Centura Health, the Compass Health System at the University of Colorado Anschutz, which includes the University of Colorado Health System and Children's Hospital of Colorado, and then the All Payers Claims Database at Civic. Across those data sources, we identified over 25,000 cases, and then we went through a process of applying our exclusion criteria. So in order to be a case, they had to have a healthcare encounter between 2011 and 2013 with a diagnostic code consistent with a congenital heart defect. So we included cases that did not have an encounter with a CHD code in that 3-year period. And then we further excluded cases that did not have a residential address in Colorado. And that resulted in a total of 16,480 cases that met our case definition. And then we performed our deduplication method, which excluded around 4,000 cases for a final total case number of 12,293. Our record linkage and deduplication process utilized a probabilistic record linkage algorithm, which was developed to compare available direct and indirect personal identifiers on each individual to determine the likelihood that 2 or more records matched within and across data sources. Our linkage variables were first name, last name, date of birth, the last 4 numbers of the Social Security number, and street number. We segmented our cases into 3 blocking schemes, and then we identified the probability that 2 cases would match based on a matching score. And so individuals were considered perfect matches if they had a matching score of 100, potential matches if they were between actually 99 and 75, and a non-match if they were below 75. After we deduplicated our data, we matched all of our unique cases from primary case finding to secondary data sources for data enrichment. So we matched to birth certificates at the State Health Department, birth records in the CDPHE Birth Defects Registry, and also death certificates between 2011 and 2016. So to talk about each of these data sources individually, birth certificates were available for query for births that occurred after 1975. So we looked for both the birth certificate of our index case, and we identified 3,047, and live births that occurred to our cases, to our female cases only. And we identified 1,031 live births. The Birth Defects Registry at CDPHE added critical congenital heart defects to their list of reportable conditions after 1996. And we did surveillance of individuals aged 11 to 64, so not many of our cases would have been captured in the Birth Defects Registry. We only identified 162 matches in the Birth Defects Registry. And then for death certificates, we identified death certificates from our cases that would have occurred in 2011 through 2017, and we identified 293. So now I'd like to talk about and present some of our analyses to evaluate the strengths and limitations of our integrated surveillance system. So this rather complex slide shows the results of our record linkage and deduplication. I've de-identified the primary case finding data sets except for the all pairs claims data source to avoid associating a number of records with a particular data source. But this figure shows the within and across system duplicates. So for example, data source 1 had one within system duplicate. So one person had 2 records within that data source. They had 8 duplicates common between data source 1 and data source 2. Data source 2 had 0 within system duplicates, but shared quite a few cases with the all pairs claims database. Data source 3 had 248 duplicates and shared 1,576 duplicates with the all pairs claims. So just to go back to that slide, sorry. This has allowed us to evaluate the contribution of each data source, of course, to our total case finding. We expected to capture the most cases through the UC Health System, through Compass, because it includes the Heart Institute at Children's Hospital, which performs most of the early operations for congenital heart defects. And it also has the sole adult congenital heart defect clinic in Colorado, which is the Center of Excellence for Care of Adults with Congenital Heart Defects. The all pairs claims database was an important data source for us because we were hoping that it would capture cases outside of our other 4 primary case finding data sources. One data source that did not participate in our project that we felt was extremely important was the Health One network. We were hoping that all pairs claims would have captured some individuals that received care through that network. And while many of our data sources have outpatient clinics, emergency rooms, and hospitals across the state, we of course want to make sure that our surveillance system is capturing not just individuals in urban areas, but also individuals that live in rural areas or areas outside of the Front Range. And finally, all pairs claims has 100% of Medicaid. And it was very important to us that our surveillance system have high external validity and not just capture individuals with insurance systems that allow them to access the centers of excellence at UC Health. And all pairs claims contributed the highest number of unique cases to our surveillance system. So we were extremely grateful for the data that was provided. So now I'm going to present results in which we analyze the difference between individuals that access care through one system versus those that had duplicate cases across other systems. So we were asking this question to know what would the effect of not having a rigorous deduplication algorithm have on our surveillance findings. And so we found that individuals that were younger and older, so on both extremes of the age spectrum, were more likely to access care across systems, that individuals of non-Hispanic white race and ethnicity were more likely to access care across systems. Individuals that had public insurance or had a change in insurance over the surveillance period, the 3-year surveillance period, were more likely to be a duplicate case or an individual that accessed care across systems. And individuals with more severe disease. So individuals with a defect that is considered severe versus one that is considered moderate or minor were more likely to access care across systems. And this is a table that looks at the major CHD comorbidities. And you can see from all the significant p-values that individuals that had CHD comorbidities were more likely to be a duplicate case than those without. So individuals with more severe disease that had comorbidities were more likely to access care across systems. And then this slide is looking at healthcare utilization metrics and inpatient hospitalization, so at least one inpatient hospitalization over our 3-year surveillance period, the median number of inpatient hospitalizations, an outpatient visit over our 3-year surveillance period, as well as the median number of outpatient visits, an emergency room visit, and then the median number of ER visits. And I'll talk more about healthcare utilization in a couple slides. But the findings here is that individuals with higher levels of healthcare utilization were more likely to access care across systems. This is probably not a surprise. If you are on vacation in Aspen and you have an emergent situation, you're going to go to the nearest emergency room. So individuals with more severe disease that have higher healthcare utilization are more likely to cross systems. So just to summarize our findings, we found that duplicate cases, both within and between healthcare systems and the all payers claims database, significantly influenced total case finding, accounting for more than 25% of our total cohort. And failure to reconcile identity would bias our surveillance findings to overrepresent individuals who were less than 18 years of age, had more severe CHD, changed health insurance status during our surveillance period, had significant comorbidities, and whom had higher healthcare utilization. And finally, the all payers claims database was a valuable case finding data source as it contributed the highest number of unique cases that were not captured in other primary case finding data sources. So we have submitted a manuscript on this topic, and we just got back our reviewer response, and they asked us, what would happen if your surveillance system was just comprised of cases from the all payers claims database? And what would happen if you excluded the all payers claims database? This is a rather complex analysis. I'm wooing you with the dark arts of epidemiology now. So this is the analysis that we did to explore that question. We did this over the weekend, so this is just a first look at this question. So to answer this, we looked at the relationship between a key risk factor, which is CHD severity, and 3 potential adverse outcomes: an inpatient hospitalization, mortality, and a major cardiac event. And we asked this question in our main surveillance cohort, which is this top group. And you can see that among our 12,293 cases, that we found a higher likelihood of inpatient hospitalization for individuals with severe disease relative to those with moderate or minor. That makes sense. We found a relationship with mortality, but it was not significant. And we found that individuals with severe disease had almost a 50% higher chance of a major cardiac event than those with moderate or minor CHD. Now let's look at that relationship in a cohort that only includes APCD cases. So this cohort is around 4,000, whereas our full cohort is over 12,000. So we're obviously going to be affected by power in this analysis. So we find that there is no relationship between disease severity and inpatient hospitalization. There was a slight elevation for mortality, but it was not significant. And severe disease actually looks like it's protective for major cardiac events, though again, not significant. So our results are quite different in a cohort that only includes all payers claims cases. Now, bearing in mind that this was all payers claims in 2011 through 2013, and I'm sure the database looks dramatically different than it does now. My understanding is at that time it included 8 commercial health insurance plans. So then finally, the bottom table is looking at the cohort without the all payers claims database. So we see similar findings to one with the full cohort. So mortality, the relationship between disease severity and inpatient hospitalization is about the same. The relationship with mortality is elevated, and the relationship with a major cardiac event is also slightly elevated. So again, this is a preliminary analysis. We're not 100% sure what to conclude, but it looks like a cohort only based on all payers claims cases would underestimate the relationship between a key risk factor and adverse outcomes, and a cohort that excluded the cases would slightly overestimate it. So now I'd like to talk about the next step in assessing the strengths and weaknesses of integrated surveillance. So I mentioned to you that we did not get participation from every healthcare organization in Colorado. We undoubtedly missed cases. So this capture-recapture analysis was conducted by my brilliant PhD student, Lindsay Duca, to determine how many cases we missed. So the completeness of our case ascertainment. She used an adapted capture-recapture method based on Poisson log linear models that incorporated consideration of potential sources of heterogeneous capture. So are there certain characteristics that make one individual more likely to be captured by our surveillance methodology than another individual? She looked at the possibility of dependency between our data sources. We expect that there would be differential dependency because some data sources refer to other data sources. And then she did model selection to determine the best model to estimate our incomplete case ascertainment. We calculated revised prevalence estimates by dividing the number of cases yielded from our models by the number of individuals in our source population, so the denominator, everyone aged 11 to 64 that resided in Colorado during our surveillance period. The factors that we found were associated with heterogeneous capture probability were CHD severity, age, and health insurance status. I'm sure everyone understands this figure. These are the results of our models, testing different models for the best model to estimate the ascertainment proportion. And our best model was the model number 12. Yes, she did 12 models. And it incorporated interactions between all of the factors that we found were associated with heterogeneous capture probability and dependency between data sources. So she tested for dependency between each data source, included interaction terms for the data sources that she found to be dependent. Okay. So I will show you our adjusted prevalence estimates in a few slides, but I want to talk about the next effort that we did to evaluate the strengths and weaknesses of our surveillance methodology. So we know that an ICD 9 or 10 diagnostic coding-based case definition is not going to be perfect. A diagnostic coding is used for clinical purposes, not research purposes. And so our case definition was based on previous studies, surveillance studies, and also our project includes a number of pediatric, adult, and adult congenital cardiologists. So we felt good about our case definition, but it is undoubtedly imperfect. And so we did a case validation of cases identified with that case definition against medical record review by a certified adult congenital heart defect cardiologist. We selected a random sample of 200 cases, and we stratified by defect severity and further by age. These are our case validation findings. We found that 82.5% of the cases that were identified by our case definition were validated in our medical record review to be true cases. If you look at this table in terms of the severity of the CHD, all of the severe cases were validated to be true cases. 6 out of the 50 shunt cases, this is a type of heart defect, were validated to be true, 14% of the valves, and 44% of the other. So we divide our cases into types of CHD, and most of the incorrect assignment of CHD case status was within that other category. So this was conducted consistently across the 5 sites funded by the Centers for Disease Control. We will be publishing our results and considering how we will use these findings to influence how we report our results over our group project. But then further, among those cases that were validated to truly be a CHD case, we looked at if they were placed into the correct severity bucket, and we found that 90% were in the correct bucket. We also, in the course of this project, have been looking at outcomes from pregnancy among women with congenital heart defects. Pregnancy is a time of elevated risk, both for the mother with a congenital heart defect and risk for the baby. But in the course of looking at this relationship, we became worried that sometimes it was not actually the mother that had the congenital heart defect, it was the infant. Because at the time of pregnancy, the infant does not yet have a medical record, and if a fetal echo detects that the fetus has a heart defect, that code goes into the mother's medical record. And so we have been looking at validating our pregnant cases as well as just our normal cases. So we looked at women whose only CHD code, so her only encounter in which a CHD was coded was during pregnancy. And we found that about 60% of those were true cases. So our case definition performs worse when it is in a pregnant woman and her only diagnosis is during her pregnancy. And then we looked at if the woman had a CHD code outside of pregnancy, and the performance of our ICD-9 case definition performed similarly to what it did in a non-pregnant individual. Okay, now I'd like to talk about our results. So I'll first talk about the descriptive epidemiology of individuals with congenital heart defects that we found in Colorado. So this is a data table that shows the demographic characteristics of our cases. And yeah, I should have this also in a figure. So our cases were fairly evenly divided by male and female sex. We did surveillance of individuals in the adolescent and teen range, so 11 to 19. These made up 23% of our cases. And then adults aged 20 to 64 made up about 77% of our cases. Looking at race and ethnicity, about 50% of our cases were white, 14% were Hispanic, 3% were Black non-Hispanic, 6% were non-Hispanic other race, and race and ethnicity was missing for about 30% of our cases. Looking at insurance type, about 59% had private insurance, 33% had Medicaid, 8% of our cases had Medicare, and about 4% were self-pay. And then we also looked at urbanicity of our cases based on the FIPS code of their census tract for their residential address. About 45% were from large fringe metro areas, so suburbs. 13% were from large metro areas. 30% were from medium metro areas. About 6% were from small metro areas. 5% were from micropolitan areas, and 4% were from non-core metro areas. So the distribution of CHD defect type. So we divide defect type into severe, shunt valve, shunt plus valve, and other. And then we further collapse that into severe and moderate or minor. And moderate or minor includes shunt valve, shunt plus valve, and other. So 15% of our cases were severe, and 85% were moderate or minor. This is just a visual showing that distribution of CHD severity by CHD type and the dichotomy of severe versus moderate or minor. These are our period prevalence estimates. So again, our period of surveillance is 2011 through 2013. Our age range is 11 to 64, and this is individuals that had a Colorado address. So our crude prevalence estimates were 3.25 per 1,000 individuals. And our capture-recapture adjusted prevalence estimate was almost twice as high, 5.85 per 1,000 individuals. Now, some of the reasons that there would be such a big difference between our crude and our capture-recapture adjusted is that individuals may have had a congenital heart defect, but may not have hit the healthcare system during the 3-year period. Alternatively, they could have hit the healthcare system, but not received a diagnostic encounter code in their medical record. And then, of course, they could have been outside of data systems captured by our project. So contrasting this from the prevalence estimates that have been generated based on Canada's surveillance efforts, they estimated 4.09. So our prevalence are of 3.25, and then our adjusted prevalence of 5.85 kind of shoulder this estimate by Canada. This figure shows the burden of comorbidities among our adolescents with CHD. So the most common comorbidity was chronic pulmonary disease, which was present in 15% of our cases, followed by cardiac arrhythmias and pulmonary circulation disorders. This is looking at comorbidities among adolescents stratified by severity. So we found that for pulmonary circulation disorders, congestive heart failure, chronic pulmonary disease, and cardiac arrhythmias, that the prevalence was higher in our severe cases versus our moderate or minor cases, which you would expect. But just to emphasize, in our severe cases, about 17.5% have chronic pulmonary disease, and around 12% have cardiac arrhythmias, 10% have the pulmonary circulation disorders. This slide shows the comorbidities among our adults with CHD. 27% of adults had hypertension, 21% had chronic pulmonary disease, 13% had cerebrovascular disease, 12% had cardiac arrhythmias. So looking at the comorbidities among adults stratified by severity, we found that pulmonary circulatory disorders, myocardial infarction, and cardiac arrhythmias were more prevalent in individuals with severe versus those with moderate or minor. However, peripheral vascular disorders and chronic pulmonary disease was more prevalent in individuals with moderate or minor CHD than those with severe. So one of the important findings I think that I see from this is that there's consideration of, okay, so your case definition operated less rigorously in the moderate or minor individuals than it did with the severe. Why not just do surveillance for individuals with severe? And my concern is that it's not just individuals with severe heart defects that have complex life courses and experience adverse outcomes as a result of their heart defect. Individuals with moderate or minor may not be managed as closely. It may not be communicated to them the importance of having consistent care with an adult congenital cardiologist. Therefore, they may be experiencing a higher level of comorbidities and potentially, in some areas, adverse health outcomes that could be preventable because they are not considered as high of a priority for surveillance and management. So I think these initial findings highlight the importance of surveillance, not just among those with severe, but less severe forms of CHD. This slide looks at our healthcare utilization metrics among the adolescents. So we looked at the total number of adolescents that had an outpatient visit during our surveillance period. It was higher for those with severe than moderate or minor. We looked at outpatient visits with a cardiology provider. It was significantly higher among our individuals with severe versus moderate or minor. And then those who had an inpatient hospitalization during the 3-year visit, again, higher among the severe versus the minor. And cardiac procedures and ER visits were also higher among those with severe versus moderate or minor. So we see a slightly different picture with looking at healthcare utilization among adults. So about 94% of those with severe CHD saw an outpatient provider versus 86% of those with moderate or minor CHD. Looking at outpatient care with a cardiology provider, which is recommended to happen at least every 2 years for adults and adolescents with CHD, 69% of those with severe disease had a visit with a cardiology provider versus 44% of those with moderate or minor. So this is one visit in our 3-year surveillance period. The number or the having an inpatient hospitalization was not significantly different between moderate or minor. About 26% of cases experienced an inpatient hospitalization. And then our severe cases had a higher level of cardiac procedures than our moderate or minor cases. And then interestingly, individuals with moderate or minor disease had a higher prevalence of an emergency room visit compared to those with severe disease. So again, this concern that maybe individuals with moderate or minor disease don't understand the importance of having regular care from a cardiologist and maybe accessing the emergency room for conditions that could potentially be preventable. And finally, I'm going to talk about some of our other research findings. So a lot of these are informed by our patient advisory group. They have told us that one of their major struggles is dealing with anxiety and depression, particularly when they know they have an upcoming procedure. So we have learned that these procedures can take up to a year to recover from, and there's risk of mortality for each procedure they have. So they asked us to look at different mental illness diagnoses. And so within adolescents and adults, we looked at the prevalence of mental illness, so having any mental illness diagnosis during our 3-year period. We found that 20% of adolescents and 33% of adults had a diagnosis of a mental illness in our 3-year period. And then we looked at subtypes of mental illness. And within our adolescents, the most prevalent type of mental illness diagnosis was anxiety, a developmental disorder, and a mood disorder. And then within our adults, the most prevalent subtypes of mental illness were anxiety, a developmental disorder, a mood disorder, and a substance-related disorder. This is particularly concerning to us because attention, conduct, and behavioral impulse control disorders in adolescence put individuals at much higher risk for substance abuse-related disorders in adulthood. Individuals with CHD are exposed to a high level of painkillers throughout their life, and so we're especially concerned that given the propensity for attention, conduct, and impulse control disorders in adolescence, that these are placing adults at higher risk for substance-related disorders. There's my boxes. And we also looked at diagnoses of chronic pain in adolescents and adults. So within our adolescents, we found that 12% had a diagnosis of chronic pain over our 3-year surveillance period, and 27% of adults had a diagnosis. So across our entire age range, the prevalence of chronic pain was about 24%. And then Lindsay Duca, as part of her PhD dissertation, looked at the transition from pediatric to adult-centered cardiology care. This is an absolutely critical care transition for individuals with CHD who are followed by pediatric cardiologists through their childhood, but then have to transition to an adult provider. And not all adult cardiologists understand the complexity of a congenital heart defect, particularly when that starts to interact with acquired heart disease as they age. So it is of great concern to make sure that this transition is happening for the majority of individuals with a CHD and to understand ways to improve the transition. So we looked at individuals who saw a pediatric cardiologist in the first year of our surveillance period, so 2011, who were aged 18 to 26, so eligible for transition. We found that 32% transitioned to an adult CHD cardiologist, which is considered an optimal transition. 28% transitioned to a pediatric or an adult cardiologist. So we consider that an adequate transition. Not ideal, but adequate. And 40% had no cardiac care in the next 2 years. Of this 40%, 25% had a severe heart defect and 47% had a mild to moderate defect. So extremely concerning that 25% of those had a severe heart defect. We're worried that this could be due to changes in health insurance that may leave that individual vulnerable. And then Lindsay also looked at predictors of a lapse in care. So she found that individuals who were non-Hispanic and other race ethnicity had were at risk for not having an optimal transition. Individuals with severe heart defects were more likely to transition to an adult congenital cardiologist. Individuals that lived in high poverty areas were less likely to transition. And drive time to the only adult congenital heart defect center in Colorado at an Anschutz campus was every increased 10 minutes of drive time was associated with a 3-fold risk of not transitioning to the optimal care. And then individuals with a chronic comorbidity were more likely to transition. So if we consider adequate cardiac care, so just continuing to see a cardiologist, but not an adult congenital cardiologist, individuals with severe CHD were more likely to continue seeing a cardiologist versus having a lapse in care. Individuals with a developmental disability were more likely to stick with a pediatric cardiologist. So many individuals with a severe developmental disability, such as Down syndrome, never transition to an adult provider. They stick with their pediatric provider their entire life, which we would expect. And then individuals with a chronic comorbidity. So finally, the public health implications of our project. So we've hoped that through this process, we have generated a better understanding of the strengths and limitations of integrated surveillance using EHR and insurance claims. Undoubtedly, there are weaknesses, but I think we've identified some strengths and we've built partnerships which I hope can support other projects in Colorado that deal with other potential public health issues or clinical outcomes, can use a similar process or can learn from our project's process in developing their own EHR or administrative data-based surveillance programs. We hope that our project has allowed stakeholders across Colorado to come together to conduct surveillance, not just of congenital heart defects, but of other topics. And we're hoping that the results of our project can increase the awareness of congenital heart defects and why they're important as a public health priority. I think we've demonstrated that there are more individuals living with congenital heart defects than were previously estimated. A lot of people in healthcare and public health think of congenital heart defects as an issue to worry about in babies. But there are more individuals that are adolescents and adults living with CHD than babies. So this is not just an issue for the perinatal period. And then I think our project really supports the idea that we need more funding or more coverage for adult congenital heart defect centers. If drive time to the sole center that is on the Anschutz campus is an issue, I think there are a variety of solutions that could be considered, including telemedicine solutions or perhaps certifying other centers in different regions of the state. And then there is much to be done to consider strategies aimed at decreasing the barrier during the transition period from pediatric to adult-centered care to avoid a lapse in care during the young adult years. So our future directions is we have applied for a grant to continue our surveillance efforts. Due to strong advocacy of individuals with congenital heart defects, the Congenital Heart Futures Act was renewed in Congress, which provides a funding base for the Centers of Disease Control to fund projects such as ours. So we have applied for another, it would be 5 years of funding if we are funded, and we would be able to increase our surveillance period from 2011 to 2013 to 2008 through 2017. So our short surveillance period really precluded us looking at trends or looking at outcomes. So an expanded surveillance period would open up a lot of research possibilities. In the next project, we will be expanding our age range under surveillance to the entire lifespan, cradle to grave. And we are considering broadening our case definition to not just be restricted to individuals that had a CHD coded in encounter during our surveillance period, but also a history of CHD. So we hope that we are successful in obtaining that funding. Finally, this is our investigative team. I'm the principal investigator, and on our team includes Amber Khanna, who is an adult CHD cardiologist, Lindsay Duca, who has now left to go to CDC herself. She was the database manager, and now Alex Tillman is the new database manager. Christopher Rausch is a pediatric cardiologist at the Heart Center at Children's Hospital. Lisa McKenzie is an environmental researcher at the School of Public Health, and David Kao is an adult cardiologist. And then Tone Ong is a computer scientist who has a academic appointment in the Department of Pediatrics, and he helps with our record linkage analysis. So thank you so much.
Wow, that's an incredible amount of information, and it's fascinating. We have a couple of minutes. Does anybody in the room have any questions? All right, we have one from Carrie, who's on the phone, and she has a couple, so I'm gonna kind of jump around, but I guess, how does Colorado compare to other states related to prevalence and the ability to study this? Do you have any idea?
That is a great question, and when we wrote the grant, we were trying to understand if we might have had a higher birth incidence. And there is concern due to our higher altitude that there may be increased risks for CHD during pregnancy, for incidence of CHD. But as I've learned in the process of doing this project, it's very difficult to compare across states. because states do not use the same methodology to conduct surveillance for CHD at birth. Now, across our other 5 sites that have conducted this same surveillance project, we just finalized our data a couple months ago, and we are in the process of making sure that even though we utilize the same protocol, we're still in the process of data cleaning to make sure that we can understand if that's an appropriate question to ask. So prevalence in the adolescent and adult population wouldn't necessarily be due to a higher risk of CHD. It may be due to a variety of factors, such as someone may choose to live in Colorado as opposed to New Mexico because they like our providers at Anschutz. If you had a baby that was born with CHD, you'd probably think long and hard about where you're going to live in terms of proximity to a medical center. So unfortunately, that's not a question that we can answer at this time, but it's certainly something that we hope to be able to assess as we sift through not just Colorado's data, but the other 5 sites.
Fascinating. Is Colorado the one with the center in the region? Or?
All of our sites have a center.
Okay.
So the other sites are Utah, Emory, so a 5-county area around Atlanta, North Carolina, so it's population-based there, and New York. And in New York, it is also a county area that excludes Manhattan, but they all have adult congenital centers within their catchment area.
Fascinating. So on this side of the country, there's only 2.
I actually don't know the answer to that, how many there are on this side of the country. Certainly, University of Utah has a long history of congenital heart defect research and treatment, and they have an ACHD Center of Excellence, and Colorado does as well.
Fascinating. What inspired this project for you guys?
So I consider myself a perinatal epidemiologist, and so I've always studied the origins of chronic disease, the fetal origins of chronic disease, and I worked in public health for many years before I got my doctorate. I worked at the state health department, and I've always been a junkie for surveillance, the methodology of surveillance. And when this grant was released a couple of years ago, they pulled together a team of mostly cardiologists and then included me just to listen to the discussion. And I kept listening to them talk about how they would do this and thinking, I can do that. I can do that. I can design a surveillance system. And I'm fortunate to have a lot of friendships with at the state health department and at different healthcare systems. And so I have the partnerships that I felt would allow me to approach the different systems and form a collaborative to develop this. So I really rely on the cardiologists for the science and the clinical implications of our findings, but I'm the surveillance junkie. So that was how it came about.
Very cool. Well, we're going to have to wrap up here just in terms of time, but thank you so much for joining us. We really appreciate it. This is very cool. And anything else you want to add?
No, it's really been a pleasure. Thank you so much.
Excellent. Thank you.